Good evening, everyone, and welcome to the ANSC Obstetrics update for RPA and Canterbury Hospital. I am Hannah Coffey, Project Officer for the RPA Women and Babies in Canterbury Hospital ANSC program, and I'm also the Intellectual Disability Program Coordinator with Central and Eastern Sydney PHN. Also with us from CESPN is Lydia Connick, CPD Program Officer, and we have Dr. Natalie Caristo, one of our ANSC GP advisors, who will be facilitating the Q&A this evening. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us tonight. A couple of housekeeping tips. At the end of the webinar, the evaluation survey will pop up on your screens. We appreciate your feedback and please complete this to allow us to issue your certificates of attendance. Throughout the session, please ensure that you submit your questions to the speakers in the Q&A function throughout the presentation. To view this box, hover over the toolbar at the bottom of your screen. I will take this opportunity to draw your attention to one of the upcoming events, which is cultural awareness training taking place on the 26th of October at the Tradies in Guyana. If you wish to register, please visit the PHN website. As always, here are some coronavirus resources. Please visit the PHN website for more information. The DFB Assist program supports health professionals to recognise and respond to signs of domestic and family violence in their patients. Mental health support can be found via New Access and Head Start. If you need some more information, please visit their respective websites. And also Project Grow provides support for health professionals to provide more effective care for people with intellectual disability. Please visit the Grow website for more information. As this is the last year of the triennium, please also note that all ANSC GPs will need to meet their education requirements to remain on the program. If you're unsure of how many points you have, please contact the team at ansc@cespn.com.au. Okay, I'll introduce our first speakers for the night. We have Dr. Ritu Mogra and Dr. Jose Garcia Flores. Dr. Mogra is a specialist obstetrician and gynecologist with subspecialisation in O&G ultrasound. She is currently head of obstetrics and gynecology ultrasound department at RPA Hospital and a consultant at the Sydney Ultrasound for Women. She completed her fellowship at King's College Hospital, London, where she developed her specialised knowledge of fetal cardiac echography under the direction of Professor Lindsay Allen. Her main area of subspecialty and research interest is early fetal echocardiography for screening, diagnosis and management of congenital heart defect, early prediction and prevention of adverse pregnancy outcomes, and monochorionic twin pregnancy. Dr. Flores was trained as an O&G in Spain, where he gained experience working as maternal fetal medicine subspecialist. He moved to Australia in 2017 and was certified as an O&G subspecialist with Franscog and obtained a diploma in diagnostic ultrasound. Dr. Flores currently works as a staff specialist in the fetal medicine unit at RPA Hospital. Please post your questions to the Q&A box and we'll get to them at the end of Dr. Mogra and Dr. Flores' presentations. Thank you both for presenting this evening. I'll hand over to you.
Thank you. Thanks, Natalie. Thanks, Hannah, for such a nice presentation. So what I would do is just let me share my screen. So it's a great pleasure to be here tonight with all of you. Today, I would be discussing about the first trimester combined screening and the non-invasive prenatal testing. So first trimester combined screening, as you all know, the gestational age at the time when we usually do it is around 11 plus 3 to 13 plus 6 weeks. And the goals of this first trimester combined screening is to screen for common aneuploidy, to do the structural assessment to identify any major structural malformations, and also to screen for adverse pregnancy outcome, particularly preeclampsia. So first, I'll take you through about the screening for aneuploidy. So you can see the most common chromosomal abnormality, as you all know, is a trisomy 21, which is a Down syndrome. So This is around 53% of the total chromosomal abnormalities. The second most common is trisomy 18, followed by trisomy 13, and then the sex chromosome abnormalities. 16% of cases are due to other rare chromosomal abnormalities. So what do we do in first trimester combined screening? So when the patient comes for this ultrasound, we obviously have an algorithm where we combine patient's age. We do the ultrasound, we look at the markers for the Down syndrome. As you can see, the presence of the nasal bone, the nuchal translucency, thickness. The Down syndrome babies, nearly 80% of them would have an increased nuchal translucency. Nearly 80% of Down syndrome babies have an absent nasal bone. We can also look at the cardiac markers, like a tricuspid valve regurgitation. And we can also look at one of the blood vessels called ductus venosus and look at the blood flow. And if it's abnormal, it increases the risk of Down syndrome. Currently, we use the ultrasound marker, mainly the nuchal translucency and the nasal bone. And if you put that into the algorithm, it gives us the detection rate of nearly 90% with a 5% false positive rate. If we do combine all other cardiac markers, then you can reach the detection rate nearly up to 98% with a 3% false positive rate. And the biomarkers we use is serum beta HCG, PAPE, and PLGF. So usually we ask patient to have a blood test done a couple of days prior to their ultrasound appointment. So they have a blood test which looks for beta HCG, PAPE, PLGF, and when they come to the ultrasound department, they have their blood pressures taken, they have their height and weight taken, and we have some history recorded. And after that, we put all this information into an algorithm and give risk assessment to the patient. So this is the algorithm we use, and it combines the maternal history, which is a background and a prior risk, and we combine with biophysical and biochemical markers, and then give the adjusted risk. So the report we generate for the patient looks like this. And in this report, as you can see, there is a background risk. Background risk is related to the maternal age. And the adjusted risk is the risk which we then generate after combining the ultrasound marker and the biomarkers. So you can see the adjusted risk here is for trisomy 21, like is 1 in 5,000, trisomy 18, very low risk, and trisomy 13, again, you can see very low risk. The cutoff we use to define the risk, the high risk is 1 in 300. So anything higher than 1 in 300 would be defined as increased risk for this chromosomal abnormalities. In this report, you can also see there is a risk of preeclampsia before 37 weeks. And I'll talk to you a little bit more in next couple of slides about preeclampsia. But the cutoff we use is 1 in 100. So anybody who has a risk more than 1 in 100 is defined as an increased risk for preeclampsia. So this is just to show you the population-based trends in prenatal screening and diagnosis of aneuploidy. So this is a Victorian study where they looked at from 1996 to 2013, how the screening has changed. So you may remember, a long time ago, we were doing the second trimester serum screening, and the first trimester screening came into play in around 2000. And since then, you can see there is a significantly increased uptake of first trimester screening. And this the next graph shows you the detection rate for trisomy 21. And you can see clearly how we have increased the detection rate of Down syndrome by first trimester combined screening. Now, as we all know, we have a really good test called NIPT. So that's a non-invasive prenatal testing. And it's really is a very disruptive technology. Well, it is a very good test for Down syndrome. And as you know, the detection rate for Down syndrome is nearly 99.7%, nearly diagnostic, and a very small false positive rate of 0.04%. And similarly for trisomy 18 and 13, the detection rate is really high with a very low false positive rate. For sex chromosomal abnormality, its detection rate is around 96%, bit lower than Down syndrome, and slightly higher false positive rate. It's not a very good test for sex chromosomal abnormalities, but it can detect up to 95% in 95% of cases. So what is cell-free fetal DNA? The cell-free fetal DNA is made up of short segments of fetal DNA that circulates in maternal plasma. And origin of these fragments is thought to be primarily from the placenta. So where does this cell-free DNA comes from? So the circulating cells go through the life cycle, which ends in programmed cellular that's called apoptosis. And as a result of apoptosis, the DNA gets cleaved into small fragments, and these DNA molecules that are released into the blood from dead or apoptotic cells are no longer part of intact cells and are called cell-free DNA. So during pregnancy, the maternal blood contains mixture of both maternal and fetal cell-free DNA. So as you know, there are many NIPT providers around, and there are different, so I'm sure you would be aware of all these companies, and you can see everyone uses different platforms. So there are different methods utilized by different laboratories, but majority of them would have a very good accuracy for detecting trisomy 21. So what are the challenges we see with the non-invasive prenatal testing? Obviously, we need to think of, once we get the results, false positives, what are the false negatives, and what do we do with the failed results, and what happens when you get the failed results? So false positive, so when you get the results from NIPT, which is high risk, but when you do the diagnostic testing, it's a normal karyotype. That's the case when it's a false positive. And the reasons for false positives are either there is unrecognized or vanishing twins, or it's a placental mosaicism, because most of these cells are coming from placenta, or there is a low level of maternal mosaicism, especially sex chromosomal abnormalities, or there is a maternal malignancy. We certainly have picked up some cases of maternal malignancy by just doing an NIPT. And false negative, it could be a genetic variant, and it could be a placental mosaicism. Now, the failed results, there are many reasons for the results to be failed. Means the NIPT, you've done the NIPT, and there would not be any results given for that particular patient. And if there is an increased BMI, so if the mom is really big, there would be high chance of failing the results. Sometimes there is failure to extract adequate material. Some of these failed results are because of the aneuploidy, which may not be 21, 18, 13, but some other signals they have seen on the testing, and therefore they don't release the results. There is a individual variation in amount of cell-free fetal DNA, and therefore some of the patient does have a very small fetal fraction. And there are some technical reasons as well, which is how you take the blood sample, how you transport it to the lab, the poor transport conditions, and so on. So the failure rate, again, depends upon which company you're using. Every company has slightly different failure rate. And you can see in this table here, some have very low failure rate of 0.8%, and some have very high failure rate of 12.6%. But overall, the failure rate is around 3.5%. And as we discussed, some of the reasons for failure actually are also if you have done very early in pregnancy, like less than 10 weeks. Again, just to reinforce, the maternal BMI has a significant impact on the failure rate. And if the maternal weight is more than 120 kilos, then nearly 20% risk of failing the result. And if 150, then nearly 50% chances of failing the result. And again, we have to be mindful, if we have a maternal medical condition, it can also affect the failure rate. And also certain medications like if patient is on low molecular weight heparin, it can also increases the chances of not getting the results. Now, there are other NIPTs also available for looking at other chromosomal abnormality apart from just the common chromosome like 21, 18, and 13. So there are some providers do provide NIPT for selected microdeletions. And there is another type of NIPT, which is called genomic-wide NIPT, which look at all other autosomal trisomies or segmental aneuploidy, but does not include microdeletions. So in Sydney, there are some companies do provide genomic NIPT. Just a slide for the NIPT for microdeletion syndrome. So NIPT is not really very good test for microdeletion syndrome. The microdeletion syndrome, as we know, are very rare. The most common one is a 22q11.2 deletion, which is a DGERD syndrome. The others are Cri-du-Chat, Prader-Willi, and so on. You can see it all on the list. The problem is the positive predictive value is very low in general population. As we know, the prevalence is very low, and the test performance is not that great. And particularly for patient who, if you're doing as a screening, who doesn't have any ultrasound abnormalities or family history. So I think it's really important to understand before sending these patients for this testing for microdeletion syndrome. So at RPA hospital, what we usually do is we do contingent screening. So we have a patient coming in for first trimester screening first, and then depending on that result, we offer them NIPT. I know as a majority of patients, particularly in private sector where I see everybody, nearly 90% of patients would have already had NIPT before they come for first trimester screening. In public hospital RPA, and what we have seen is 20% of patients, 20 to 30% would have already had NIPT, but majority of them do not have had have not had NIPT done before. So when the patient comes into the hospital, we do the combined first trimester screening as a primary test. And then we have, you would have seen the results, how the results come. Either it would be a high risk result. High risk is usually defined as cutoff of more than 1 in 300. But we have this algorithm where if woman is very high risk of having Down syndrome, the risk is more than 1 in 10, then we go straight to the invasive testing, because this is obviously comes in a very high risk category. If we define intermediate risk, where the risk is between 1 in 10 to 1 in 2,500. And in these cases, we do discuss with the patients about having an NIPT. I should say, I have missed one of the points here, but if the risk is between 1 in 10 to 1 in 300, we do discuss NIPT versus diagnostics testing, which is either CVS or amniocentesis. If the risk is lower than 1 in 300, but between 1 in 300 to 1 in 2,500, then we offer patients NIPT. These patients are low risk, but if you really want to improve your detection rate for Down syndrome, then we have chosen the cutoff of 1 in 2,500. And this is based on picking up nearly 90%, 98% of Down syndrome babies. So as I mentioned before, if you do the contingent screening and if you use the cutoff of 1 in 300, then you have nearly 90% detection rate. But if you do want to increase your detection rate by doing the contingent screening, then obviously you could choose a cutoff where you can do the NIPT testing for these patients, and also improve the detection rate, not doing the NIPT for whole population, but just a subgroup of patients. And yes, if the NIPT comes back negative, no further testing is required. But if the NIPT comes back positive, then we offer them invasive testing. So for the patients who already have NIPT done and they've come for first trimester combined screening, we usually don't do any further new risk calculation unless there are structural malformations, and in that cases we obviously do need to offer the invasive testing. So these are the issue guidelines. This is our International Society of Ultrasound in Obstetrics and Gynecology. So they also suggest all women who already had so all women who had NIPT should not have a new FTS risk calculation, but women who already had NIPT should be offered first trimester ultrasound. So obviously, when I said NIPT is disruptive because it's no doubt it's a very good test for Down syndrome, but what sometimes happens is once patients have NIPT, some of these patients don't come for first trimester ultrasound. I think the role of ultrasound is still very important, because the ultrasound can assess the nuchal thickness, and I'll show you why the nuchal assessment is important. It can also screen for structural anomalies. It can also screen for placental insufficiencies, and it's important to diagnose the twin pregnancies early in gestation. Therefore, we can make a management plan for these pregnancies. So this is a picture of the fetus where you can see it's a mid-sagittal position, and you can see this black space here is the nuchal thickness. And you can see this nuchal thickness is really thick. It's more than 3.5 millimeters. And you can see in this graph, as the nuchal translucency increases, the risk of chromosomal abnormality significantly increases. So even though patient have low risk NIPT result, but if you do the nuchal translucency, look at the nuchal translucency, and if it's really thick, then it's not Down syndrome, but it could be other chromosomal abnormality in a setting of low risk NIPT. So if you look at this slide, and the cutoff of nuchal translucency, we have a cutoff according to gestational age. You can see as the nuchal translucency increases, the risk of atypical chromosomal abnormality is significantly increased. So the atypical chromosomal abnormality is the chromosomal abnormality which is affecting other than 21, 18, and 13, and any small part of the chromosome missing, microdeletion, or duplication is atypical chromosomal abnormality. So if the nuchal thickness is more than 3.5 millimeter, nearly 1 in 43 of these babies will have an atypical chromosomal abnormalities. And that's the cutoff we use to offer for the screening for this group of patients. Now, next couple of slides, I would just show you the risk of adverse pregnancy outcomes. So I think ultrasound is very important. And currently, we are doing the prediction for preeclampsia. We don't have a very robust algorithm for prediction of preterm labor or for fetal growth restriction. But for preeclampsia, I think we do have a very robust algorithm. So as you know, the maternal history is very important. So it's a priority risk, and you can see if the mom is older or overweight or some of the ethnic background obviously have a higher risk. If it's IVF pregnancy, if it's have maternal medical conditions, the risk of, or if you have a previous preeclampsia, the risk of preeclampsia significantly increases. But if you just take the history, the detection rate is not as high. With the 5% false positive rate, you can see the detection rate is around 50-56%. But if you combine this with the ultrasound, So on ultrasound, we look at the uterine artery blood flow, and then combine this with the maternal characteristic. You can see the detection rate significantly increases. And then if we combine all these parameters, which includes the maternal history, uterine artery Dopplers, the blood pressure, and the biomarkers, which is PLGF and PAP-A, you can see the detection rate can reach up to 90% with a false positive rate of 5%. So which is a very good test, reaching up to the 90% detection rate. And this is a work which we did with John Hyatt, did with one of the PhD student, and looked at our population. And you can see we did reach nearly 91%, 92% detection rate with 10% false positive rate. So this test does perform well in our population. And we know from the there is a lot of evidence demonstrating the low dose aspirin starting from 12 weeks of gestation does decreases the risk of the early onset and late on, mainly early onset preeclampsia. So if you define patient who is at increased risk of preeclampsia, then we do advise them to take aspirin starting from 12 weeks of gestation and going up to 36 weeks. The cutoff we use to define increased risk for preeclampsia is 1 in 100. So any patient who is more than 1 in 100 would be given advice for starting aspirin. Now, the other thing we do, as I said, the structural survey, I think it's really important. Even though you have a low risk NIPT, it's important to assess the anatomy of the baby, because and it's important to recognize the major malformation, which we can pick up in early pregnancy, which obviously some of these are not compatible with life. So anomaly is considered to be nearly always detectable, approximately 90 to 100%. So we can detect acrania every time we do the scan at 11 to 13 weeks. Anencephaly, lobar holoprosencephaly, encephalocele, ectopia cordia, gastroschisis, megacystis, body stack. This is just some of the abnormalities. We should not miss that. And it is really important because it gives patient an early option for termination if that's the pathway they want to go ahead. There are some anomalies considered potentially detectable, and you can see there is a wide range of variation in detection, different studies. And the reason being is different centers uses different protocols. So obviously everything depends upon how hard you are trying to looking at and what is your protocol. So if you have a very extensive protocol looking at all the structures in first trimester, certainly your pickup would be up to 90%. And if you don't look at, you obviously are not going to find these things. There are certain anomalies we cannot detect in first trimester because these either are not present or brain. As an example, corpus callosum agenesis, the brain is still developing, and not even the corpus callosum even have started developing at this very early stage. There are certain things which develop as baby grows, so like some lung malformations, and like a duodenal atresia. These are the things you see only in later part of the pregnancy. But the take-home message is the structural survey is important to identify the anomalies which are very incompatible with, not compatible with the life. So the other thing I really wanted to draw attention is the first trimester scan is again very important to define the chorionicity, because as you know, the monochorionic and dichorionic twins, they both are high risk pregnancy, but having a monochorionic twin monochorionicity increases the risk of complications significantly. So you can see the monochorionic twin miscarriage risk is 6 times more, the perinatal mortality is 2 times more, IUGR 2 times more, and again the preterm delivery is 2 times more. So identifying this is again, I think it's very important. And I think what is really important is the obstetric care, the reversing the philosophy of obstetric care means 12-week predictive modeling. So I think it's really important to identify patient at high risk in the early gestation, particularly for chromosomal abnormality, for adverse pregnancy outcome, structural malformations, and if they are monochronic twin, then twin related complication. And then define them into high risk and low risk group, and the low risk group can be then cared by the midwives, or a low risk in a low risk setting, and the high risk group can be then cared by the specialist. Then again, regrouping at 36 weeks, and we could do predictive modeling for, again, the stillbirth, HIE, cesarean deliveries, perinatal trauma, shoulder dystocia, and the other things. So I think that's all I really wanted to cover in the first trimester combined screening. So thank you so much for listening, and I'll be happy to answer the questions at the end of the second presentation. So thanks once again.
Okay, so I think it's my turn next. Thank you very much, everyone, for being there, and thank you very much for the invitation. So my name is Jose. I'm going to go a little bit through the same topics that probably Ritu has explained, but from the point of view of some practical cases. All these are actual cases we've had in RPA for the last year, a couple of years, and I will go through some basic concept again. So let's start with the first case. So this is a low-risk woman with no medical history of interest, first pregnancy. She has her NIPT already performed in the first trimester, and she has a low-risk aneuploidy. But by the time she arrived to us and we did the 12-week scan, there were very significant findings. So the structural survey was quite abnormal. So you can see that's an axial view of the fetal head, and there's one single ventricle. There's no midline there, and that's suggestive of holoprosencephaly, which is it's associated to a high rate of underlying aneuploidies. And we were able to get a nice view of the fetal heart, and you can see a broad interventricular defect connecting both ventricles. So obviously, given all these findings, even with a low-risk NIPT, we offered, and she did a CVS. And a couple of days later, that came with trisomy 13, and which is quite consistent with the findings we got to see. And then she decided proceeding to a TOP. So as Ritu mentioned, NIPT is quite a good screening, but it's not perfect. So particularly you see this is the meta-analysis by Mark Hill, which is has been updated a couple of times in the last few years. And basically, we're still at some point between 98 to 99%, highly sensitive for Down syndrome, a little bit less for trisomy 18 and trisomy 13. And as Ritu said, so there are several cases where we're going to find false positive and false negative, and that's when the NIPT is not performing perfectly. You can see that there's a pool of cell-free DNA when the sample we're taking. We're particularly interested in the placental or the fetal cell-free DNA, but that's going to be probably something between 5 to 10%. Most of the cell-free DNA is going to be coming from a maternal pool, and we have to play with all of that. So obviously that's where the false positive are coming from, because we're detecting abnormal DNA from a different origin, which could be mom. This applies particularly to sex chromosomal abnormalities, or even an abnormal DNA coming from maternal malignancy, as Ritu mentioned. There are certain cases where it's actually coming from a pregnancy for a vanishing twin, which hasn't been detected, but is still dumping DNA into the maternal circulation, or the actual placenta of the singleton pregnancy we have in front of us, but actually that placenta is behaving as a confined placental mosaicism, and otherwise that fetus is not affected by any type of aneuploidy. The false negative is the actual nightmare of any commercial house offering an NIPT, and it's actually the real false negative is a true fetal mosaicism, when we have a fetus which is actually affected by aneuploidy, and the placenta, which is the source of cell-free DNA, is normal. And originally there was an issue with the low fetal fraction, particularly for trisomy 18 and trisomy 13. The fetal fraction is slightly lower, and that's why more and more often from that, to avoid those false negatives, or most of these have been reported as non-conclusive instead. So what's happening with the low fetal fraction, with that inconclusive result? So as you can see, the problem, the whole concept is coming from this graph. So as you see, the more fetal fraction we have, the better we can tell the difference between the aneuploid population and the normal euploid population. So if we go to a low fetal fraction area, so they tend to overlap. And if we are playing with a sample where we have a low fetal fraction, so the more likely we're to have that false negative or false positive or false negative result. So the most likely scenario when you have a low fetal fraction or an inconclusive result in front of you, so you're going to have like a patient which has taken the sample too early, or it's a patient with a high BMI, IVF on heparins due to infertility or subfertility. That's somehow reassuring. So that's somehow telling you that there are some risk factors. But what's actually not reassuring is that we know in a proportion of those patients, there will be an underlying fetal aneuploidy. So the actual fetal aneuploidies which would be giving this sort of result are going to be basically aneuploidies which are presenting with placental insufficiency, which is basically trisomy 13 and trisomy 21, trisomy 13 and trisomy 18, sorry. Whereas the trisomy 21 Down syndrome is going to actually increase slightly the fetal fraction. So if you think about it, here you can see, this is a review in the last few years. Actually, the fetuses with trisomy 21, they have even a lower non-whole result compared to normal population. Whereas if we go to the trisomy 13 and trisomy 18 population, it has a slightly higher rate of inconclusive result. So in this population, basically in a failed cell-free DNA, we're still working out a clear algorithm of how to manage, but it definitely, given that we are particularly interested in picking those trisomy 13 and trisomy 18 population, definitely we need to go through that structural assessment and through that ultrasound. So first conclusion, detailed first trimester ultrasound may be useful to detect structural anomalies in that inconclusive result in NIPT, and definitely is going to make a difference in terms of the management of those patients. Second case, so it's a similar one. It's a patient you're sending to have the 12-week scan. She already has that NIPT, which is low risk. And then we have this very major finding where a fetus that should have a well-ossified cranial vault is absent, and the brain tissue is basically exposed in the amniotic cavity, and that's an exencephaly. We usually, every time we see a major anomaly, we offer the possibility of doing an invasive testing, and in that case, it was performed. This was normal, actually, which was in keeping with the low risk NIPT, but obviously, given the very poor prognosis, so this patient decided early termination of pregnancy. Brought also a couple of examples of very major, these are all our cases, very major findings in the first trimester scan. Here you can see massive herniation of all the abdominal organs, that's liver, that's bowel, and probably a little bit of the bladder. And here you can see even the heart is herniated out of the thoracic cavity through a low sternal cleft. And obviously, once more, and we'll go back to this later, very thick nuchal. Okay, this is maybe sometimes warning in not more subtle, obviously, anomalies. And there you can see another body anomaly where there's a herniation, extra amniotic herniation. There you can see that stomach, that's liver, that's bowel, which is basically stuck to the placental surface. So this is called a pentalogy of Cantrell or ectopia cordis, and this is what is known as a fetal limb body wall complex or body stock anomaly. So as Ritu mentioned, there's guidelines in currently in international guideline for them. What we should be checking, not only the nuchal translucency scan, we should be checking way far more than that. There you can see the very nice pictures about the ideal views that we should be getting. You can see the brain, like the two hemisphere instead of that single ventricle. This is what we aim to see with the nuchal translucency. But this view is beautiful because we're not only seeing a nasal bone and nuchal translucency for Down syndrome, we're also seeing what we call the intranuchal translucency, which is a screening which is performing moderate sensitivity for screening of neural tube defect, of open neural tube defect. Tertiary center like RPA, we really try to get the best of the cardiac views with or without Doppler, and obviously fetal limbs, abdominal defects, spine defects, and long list. Long list of which, as Ritu mentioned too, there's a list of defects, major defects that should be picked in the first trimester, like the ones I have presented, and basically acrania, anencephaly, holoprokencephaly, large defect with herniation like omphalocele, body stock anomaly, there you can see them. So why? Because this patient, if they can be diagnosed with this defect, even if they're not particularly associated to a high risk of underlying aneuploidies by themselves, they have a very poor prognosis. They have the option of undergoing, if that's their choice, an early termination of pregnancy rather than detecting this at 20 weeks with the morphology scan. The last case or the last concept that we would like to review is this patient without any medical history of interest, NIPT performed once more, low risk of aneuploidies, and then the 12-week scan is again very abnormal. There's a very thick nuchal that you can see. That's an axial view of the fetal head, and this is the neck, this is the back of the neck, and this is what is called cystic hygroma. Okay, that's a very thick nuchal. But the NIPT is low risk. This is usually one of the first comments when you talk to this patient. We did a CVS to this case, and it was normal, which actually the NIPT was right. So there's apparently no underlying aneuploidy. So we booked this patient a couple of weeks later, 14 weeks. The nuchal is still thick, not that dramatic, but it's still significantly thick. We were lucky enough to get a good view of the heart, which was completely normal. As you can see, this is how we see it for chambers. There's an outflow tract here, an outflow tract there. With Doppler, it was normal. So we decided, given that there was a significant thickening of the nuchal translucency, sending this patient to consultation with genetics, and they can actually go one step beyond the macroarrays and the detection of aneuploidies of deletion or duplication, and we can sequence proteins which we know were associated to syndrome, which can present with a thick nuchal translucency. This patient in particularly had, they usually take like 2 to 3 weeks to come back. And this patient by 16 weeks, she got the diagnosis of Noonan syndrome because there was a homozygous mutation in this protein, and she decided undergoing a termination of pregnancy. So this is another example, for example, where we have a very thick nuchal, and doing a little bit more investigation, we can get to see that the cranial vault is there, but it's not ossified. And when we studied that, I don't have those pictures, but when we studied the limbs were significantly short, and it was highly suggestive of a little skeletal dysplasia. This patient, just based on ultrasound findings, decided terminating, but the CVS offered as the diagnosis, homozygous mutation in a gene involved in the osteogenesis imperfecta. They're both carrier, and we're giving this patient the option of doing screening of the fetal status for future pregnancies. So basically the learning here is that even if we have an NIPT, we can have a baby with other rare syndromes, and the nuchal translucency still have a value for that, because the thicker the nuchal translucency is, the higher the proportion of aneuploidies we're going to have in these babies. Most of them will still be the major ones, the one picked by the NIPT, but proportion of them, probably something between 3 to 4%, will be others, and that will be picked by CVS. And actually, further, probably something around 5% will be single gene mutation or some sort of genetical syndrome. So we really have a role for the ultrasound here, and particularly a thick nuchal translucency. And the nuchal translucency measurement continues to have a role, and fetuses even with a low risk NIPT, and not only for genetic syndrome, also for major fetal abnormalities, particularly congenital heart disease. And that population probably deserves to be picked at the first trimester. So I would like to end with this study, which I find it's really, really nice, because it's telling us basically women who are doing NIPT, should we be doing ultrasound at all, or which percentage of patients are going to have unuseful information if we just did an NIPT. And you can see that 3% of women would have a structural anomaly or an anomaly of some sort that would have been picked in the first trimester. 6% of women, 6 to 7%, would have a miscarriage or pregnancy, a non-viable pregnancy. 1% would be multiple. 5% would have actually a redating of the gestation, which potentially might be affecting the gestation while we're collecting the NIPT. And if we put everything together, 15% of patients might be having an information that might be impacting the NIPT in the first trimester. So last slide. Basically, when you have your patient in front of you at the end of the first trimester, you have to wonder all these questions, probably more, but from a fetal point of view, is the pregnancy in the uterus, is it viable? Is it alive? Is it a single pregnancy, or are we in front of twins undiagnosed? And what is the actual dating of the pregnancy? Probably these three are going to be picked by a dating scan, and probably should be picked a little bit earlier than 12 weeks, particularly if we think about an ectopic pregnancy. And then after the dating scan, we go for NIPT. So and that's going to be screening for aneuploidies, for the 4 major aneuploidies. But you have to consider that if we do a 12-week scan, we're going to revisit again the dating of the pregnancy. We're going to obviously give viability around 12 weeks, and we're going to do screening for aneuploidies. This doesn't exclude, NIPT continues to be the best screening for Down syndrome, but obviously the NT, a thick NT, is going to give us information as well. And on the top of that, we're going to be screening for preeclampsia, and obviously we're going to be doing a significant early morphological assessment of the fetus. And that's everything I had to review with you today. I'm leaving my email here, my contact. So as a practical conclusion, I think we're very happy to take any type of consultation of high-risk patient, second opinion, anything that you have in terms of thick nuchal, high-risk NIPT. Please don't doubt to reach out, and we're very happy to see this patient. We understand it's very stressing for you, very stressing for the patient, and we're very happy to see them, usually aiming to see them in the next 2 to 3 days. So please contact us. We're very happy with just any question or anything you have. Yeah.
Thanks, Jose. And I would also like to reinforce as well, we're very happy to get any referrals for high-risk cases. And yes, we are open for, providing nuchal translucency services. to all the RPA patients. And currently, obviously, it's first come, first serve. And we are doing nearly 3,000 nuchal translucency scans. So, but if you have any questions, we're very happy to take.
I've got some questions here, so I'll try and put them together. So the first one is, the first slide is with regards to accessing the NIPT at RPA. Can that be done without Medicare?
So NIPT is not Medicare rebatable at the moment. So NIPT, all you refer to RPA or any other providers, there would be a charge. We currently have a provider which is Natera, and this is the cheapest actually provider. So we charge $350 for NIPT. NIPT can be booked. We have a couple of sessions, and we're very happy to do NIPTs for any patients who wish to come to RPA.
So you said the other question was, can you have NIPT if you don't want the first trimester screening at RPA?
Yes, definitely they can have NIPT at RPA. Sorry, what was the question? If they don't want first trimester screening?
Yeah, I think the combined one. So if they, because you said that was offered if they were higher risk, but if they, couldn't they just go at RPA, just offer the NIPT straight up with the ultrasound rather than the combined first trimester screening?
Yes, so patient can have NIPT, but we still do the ultrasound for structural survey and pre-eclampsia screening. And as I mentioned in the talk, if patient wants to have NIPT, then we do release the result for first trimester combined screening till we get the results, because an NIPT result does take 2 weeks to come back. So either they have at 10 weeks, and then when we do the first trimester combined screening at 12 weeks, we already have a results for NIPT. In that case, we don't release the first trimester aneuploidy result if NIPT is low risk, but we do structural survey and preeclampsia screening.
Okay, thank you.
We also have patients which are declining any type of screening for aneuploidies, and still when they're told about this option, they're happy to have a 12-week scan for structural survey and preeclampsia screening. In that case, we don't release the risk for any type of aneuploidy again.
Okay. Yeah.
Yes, yes.
A couple of questions on low levels of fetal DNA. Could this hint at placental disease? And someone said that these people then went on to, a couple of them went on to have IUGR, and was this a coincidence or anything?
Yeah, so I think it's a very good question. And the low fetal fraction, as we mentioned, there are many reasons for it. Some of them could be placental diseases, and some of them could be the aneuploidy. So when there is a failure of the result because of low fetal fraction, we look at why the reason why there is a low fetal fraction. In regards to the management of these cases, we do offer repeat testing for these patients, but 50 to 60% of the time, they still would not get the results on the repeat testing. And in that cases, we do have a discussion. We do the full anatomical survey again at 15, 16 weeks for these patients. And we do offer them invasive testing because there are risks of some aneuploidy in this group of patients. And yes, we do, because of the risk of placental mosaicism in this group, we do offer them serial screening to detect for early onset IUGR or other pregnancy complications.
Yeah. Okay.
So this is certainly a high risk group. Yeah.
Yeah. It says someone asked. It seems that the nuchal translucency scan, I think NTU, they've said, I think that's what they mean, scan is more predictive of abnormalities than an NIPT, which is more expensive. I suppose they're looking for different things. Is that, I just wanted to clarify that.
Yeah. Jose, do you want to answer, or do you want me to answer?
No, I'm happy to answer that. Basically, if we just need to answer which one is the best screening by itself for Down syndrome, trisomy 18 or trisomy 13, the answer is NIPT. NIPT is the best screening by itself. What I think the bottom line here is like, just because we have a better screening for Down syndrome, it doesn't mean that the ultrasound needs to come out of the picture, because it's going to give us way far more information, like a broader scope that the NIPT by itself is not giving us. So obviously, if we have, for example, one of the cases like thick nuchal translucency with low risk NIPT, so that baby is not going to be Down syndrome. And usually I tell them, like, look, this baby is not going to be Down syndrome. I highly doubt it's going to be trisomy 13 or trisomy 18, but there's more to on that list than just the big four. And actually, even for sex chromosomal abnormalities, as you said, the prediction rate is not that good. So definitely that patient needs to come out of that low risk population into a high risk that requires invasive testing and requires way far more.
Yeah. Okay, a couple of questions about dating scans. I think I know the answer to this one. RPA do dating scans? I don't think they do.
RPA doesn't do dating scans currently. And for the NIPT as well, we prefer patients to have their viability scan done outside. And when they come for NIPT, if the scan is done 4 weeks prior to their NIPT, then we do offer them a viability scan, but it's not a routine to do it. I've just looked at some of the questions, sorry, Natalie, just to jump on, but I was wondering if I could just answer some of the preeclampsia questions.
Yeah, that's where I was going next, yeah.
Should I go ahead and do that?
Yeah, go ahead, yeah.
Thank you. I think some of the questions were in FTS, NT with preeclampsia screening bulk billed. I have had some patients say that some providers charge. So we at hospital do not charge anything extra, but I understand outside providers are now charging extra for preeclampsia screening. And the reason being, it is a lot of work because they have to do blood pressure, they have to combine risk and do the results. And I think that's the reason they're charging extra for preeclampsia screening. Natalie, you can screen some of them. But
I was just going to say, there's a couple of questions about should everyone be having a dating scan? Someone asked that, guidelines said not to do it unless you're uncertain about dates, and also should we be offering every patient the preeclampsia screen? So
look, we strongly believe the preeclampsia screening, we have a very robust test we can do with the high accuracy and a good detection in first trimester, and giving aspirin to increase risk of preeclampsia woman does decreases the complication. So we strongly believe and we think everybody should have a preeclampsia screening at the time of first trimester combined screening.
And the dating scan, is that something, is there guidelines on that?
The dating scan, look, having a dating scan is good. But if dating scan is not done, then, at least 11 to 13 week scan, that is most important, because you could still do the dating at that time. You could still define the, twins or singleton. So it's not 100% necessary. You need to have a 6 to 8 weeks dating scan. The most important scan is a 11 to 13 week scan, because you could date at that time.
Yeah, okay. Someone's written here, sometimes I request a first trimester new NT scan, but then told this cannot be done. You have to request an early morphology scan. Is this the case with the terminology we are requesting, or do we do an NT scan, and is the timing the same?
So it should be the same. I'm aware that when some patients turn up more than 14 weeks, which would be the late limit for performing all this calculation, including the risk of Down syndrome, the risk of preeclampsia, the algorithm are not working beyond 14 weeks, but we still offer them that early morphology scan, because we can still do the structural survey. Probably we can still measure the nuchal translucency, the nasal bone, even if we can't combine them in to give a combined risk. But we still offer. Those are the cases I know. Otherwise, they should be booked as a nuchal translucency scan as such.
Sorry, what should be booked as a nuchal?
Yeah, if they're coming 11 to 14 weeks, that should be a nuchal translucency scan. Yeah.
Okay, great. So I suppose then someone else asked, should we, so we combine like an early structural assessment goes with the NIPT, and the PAPA and the beta HCG goes with that's the combined first trimester screening. Is that differentiated on the language?
Yeah, so I think this early structural assessment we usually define when patients are coming a bit late, around 14 to 15 weeks of gestational age. But if they're coming, as Jose said, between 11 to 13 weeks, even though they had an NIPT outside, we still define them as first trimester combined screening or nuchal translucency scan. Yeah.
And do patients have the bloods and the nuchal on the same day? Oh, sorry, Hannah, last question.
Last question.
Bloods and the nuchal on the same day?
I can answer that. I read the question, Natalie. So so they can have, the reason we do the bloods couple of days prior to their ultrasound appointment is because then we have results available at the time of a scan. So therefore we can do the counseling for any abnormal results. Patient can have scan and blood test on the same day, but then you don't have results for the blood test to combine with your first trimester screening and give the results at the same time. They don't need a referral for two referrals for blood test or the nuchal scan. We usually send patient the blood form, so patient can then take the blood form to the pathology department. We have instructions and in their email appointment, booking appointments. I think we are running over time.
Thank you very much. There's lots of questions, so we will take them down, and we'll send them off to Ritu and Jose and circulate the responses with.
Definitely very happy to answer any questions, and feel free to contact us anytime. We're very easily approachable.
Thank you very much. Thank you, Jose, and thank you, Ritu.
Thank you very much.
Thank you so much.
Our next presenter is Maria Heaton. Maria is a mother of 3 children. 2 of them were diagnosed with isolated lysencephaly sequence. Maria is currently acting in the program manager role for STRIDES, the specialist team for intellectual disability at Sydney LHD. She has over 30 years nursing experience and has worked as a clinical nurse consultant in paediatric palliative care and intellectual disability. Maria is a passionate advocate for people with intellectual disability, and in 2012 was the New South Wales Carer of the Year. Over to you, Maria. Thanks.
Thank you, Hannah. I'm just going to share my slides now.
Thanks, Maria. We can see those.
The slideshow hasn't started, isn't it?
The slideshow hasn't started. We can see your PowerPoint window there.
Oh, yeah. Thank you, Hannah. Yes. My presentation is fully scripted to help me keep to time, and I have to kind of give you the heads up that it can be a little bit emotional. So I've been involved in advocacy for people with intellectual disability since 2002. And my motivation for presenting this paper is to help health professionals view their interactions from a family's perspective. I have stayed involved in the advocacy space for all of these years because I believe that health professionals want to learn how to support people with intellectual disabilities and their families. By sharing my family's experiences on our health journey and by talking about the impact it had on our lives and how it could have been done differently, I hope to motivate you all to amend your practice when dealing with people with intellectual disability and their families. Over the course of my children's lives, we had many encounters with various health professionals. Good encounters left us feeling supported and heard, and difficult encounters left us feeling hurt, unsupported, dismissed, and worthless. Attitude is everything. I always found that when the intention of the health professional was to help us, it shone through, and no matter what they did, we understood that they wanted to help us. What I mean by this is that the most devastating and difficult conversation can be done with compassion and kindness. We could immediately feel when a health professional had a could not be bothered attitude. We could feel when they felt that our children were a burden on society and we were wasting their valuable time. Since my paper revolves around my family, I would like to introduce you to them. My family comprises of my husband, Fabian, who is an avid cricketer. He also works in health and is actively engaged in enhancing the health of his colleagues by organizing a team in the city to serve in fundraising for the Prince of Wales Hospital Foundation. My eldest daughter, Danica, is now 28 years old and lives in Canada. She graduated from UTS with a Bachelor of Design Visual Communication. Danica is a bright, independent young woman who is kind and compassionate. She advocates for the environment and animal welfare. My son, Tristan, was the gentlest person. He had an amazing calmness about him, and being a witness to his life is what started my advocacy journey. Tristan died in 2014, just 2 months short of his 18th birthday. My youngest daughter, Tiana, was so gorgeous and feisty. Her ability to communicate her likes and dislikes were incredible. Tiana sadly died in 2003, aged 3 years and 3 months. Fabian and I arrived in Australia single in 1991, were married in 1992 and settled in Sydney. Earlier that year, I had become unwell and needed to access the public hospital. That experience taught me the difference between being a public and a private patient and the impact of a doctor's communication style. The consultant was an older male. He barely spoke directly to me, did not answer my questions, and was very dismissive. We were new migrants trying to establish ourselves in the midst of a recession. Security was everything, and in spite of our financial situation, we chose to go down the private obstetrician path when I became pregnant. My antenatal care was straightforward, except that my morning sickness lasted all through my pregnancy, and Danica arrived via a normal birth, healthy, active, and well. Fabian and I decided to try for another child when Danica was a year old, and I became pregnant very quickly. We saw the same obstetrician, and compared to my previous pregnancy, I only had a short period of morning sickness and felt well. Tristan arrived on September 20th, 1996, via a normal delivery which had progressed very rapidly. Start to finish was around 4 hours, and I barely made it to the hospital in time. Fabian and I were over the moon and so happy to have completed our family. When he was hours old, I noticed that on expiration, there was a squeaky sound. I asked the nurse to check him, and he was whisked away to the nursery, checked over, and given some antibiotics just in case he had GBS. He only spent one night at the nursery, and we were cleared to go home. While in hospital, because I was a private patient, Tristan was checked by a private pediatrician, and Fabian and I were taken aback to see that in his blue book, the pediatrician had ticked that he had checked Tristan's penis and scrotum, but then written in the comments, normal, healthy female rather than male. We went home and had the happiest 12 days of our life, but on day 12 at 7 a.m., Tristan had an extremely subtle seizure that could have easily been missed. However, I was breastfeeding at the time and noticed that he stopped feeding. One hand twitched rhythmically for a few seconds, and then Tristan gave the loudest cry he had made since his birth. It was so unusual that Fabian came running into the room to check and proceeded to convince me that I was mistaken, I was over-medicalized and always thought the worst. Fabian left for work and I could not shake my unease. I worked at a local metropolitan children's hospital and knew the neurology fellow, so I called her. She asked me to present to the emergency department in a non-urgent way since Tristan appeared to be back to his normal self. Fabian and I had no support around us. We only had our work colleagues and neighbors. I had to leave Danica with a neighbor so that I could concentrate on Tristan when going to the emergency department. They checked him over, did a full screen, including a lumbar puncture. When all the results were normal, they sent him for a CT scan and transferred us to the ward that I worked on. They told me that it would be more comfortable and that I could wait there for the results. By then, Danica had been at the neighbors longer than we had told them, and so Fabian rushed over to pick her up. The ward nurse stuck her head in and told me that she was rushing off to a hair appointment and that she would chat with me tomorrow. A little later, while I sat on my own with Tristan, A number of staff walked into the room and my heart sank. I knew that it could not be good news when I saw the head of social work and my nursing unit manager in the group. They asked for Fabian and said I should call him to return immediately and that they would wait outside for his return. Everyone quickly left the room except the registrar whom I had contacted earlier. I thought that Tristan might have had an intraventricular bleed due to the rapid delivery, and I asked her what the worst case scenario was. She told me an anatomical malformation which was incurable. I felt panic set in. I was afraid to become emotional because I was in my workplace. Fabian arrived soon after. One of the nurses took Danica, and the consultant proceeded to tell us that Tristan had a malformation of his brain which was incurable and that they could only try to manage symptoms. She said that he was most likely blind, deaf, and intellectually zero. I asked her what intellectually zero meant, and she said it meant that Tristan would never recognize me as his mother or Fabian as his father. She even added that he would most likely die within a month. She said that her diagnosis for Tristan was a condition called Leeson-Kefli. I had never heard of this diagnosis during all of my training. The consultant kept asking Fabian and I to step into the doctor's office to view Tristan's brain scans, and I declined. My brain had frozen the minute I heard that Tristan would never know that I was his mother. I could not even process that he only had a month to live. The consultant told us that the seizures would return, and it was just a matter of time. We were told that we could go back home on gate leave, and we should return in the morning for further discussions. There was a lot of concern for my well-being, and Fabian was told to look after and support me. There was very little concern shown towards Fabian's well-being. I asked for some written information about Leeson-Kefli. Everyone then left the room, and the social worker stayed with us. She asked about our support, and even after explaining that we only had very distant family who were not in touch, she encouraged us to make contact with them. She told us that since we only had a month left with Tristan, we should tell all of our family and friends so they had a chance to meet him. She asked about our religious beliefs and encouraged us to proceed with urgently arranging Tristan's baptism. Before we left, the registrar handed us some reading material and we left the hospital. It was not even 12 hours since Tristan's seizure, and we already had a confirmed diagnosis. When I got home and read the journal article, it was the autopsy results of fetuses with Leeson-Kefli. It mentioned that Leeson-Kefli is also called agyria or smooth brain, and that the brain of a child with Leeson-Kefli is so primitive that even a mouse has a more sophisticated brain structure. I could not read any further, and it was a long time before I could look up any information on Leeson-Kefli. We informed family and friends and were inundated by calls and questions, which added to our stress. The next day when we returned, we viewed the scans, even though it meant little to us. We asked if this could have been detected antenatally, and the neurologist told us that it's only possible in the 8th or 9th month of the pregnancy to be able to adequately see the folds of the brain and to know if the brain was developing normally. We had a lot of information repeated to us, and this continued for a long time at almost every medical encounter. I used to think that often our happy demeanor was misconstrued, and the assumption was that we did not grasp the enormity of the situation, or we would not be so happy. Fabian and I were puzzled at the constant repetition of Tristan's poor prognosis. Fabian said that we walked into the clinic room with our head held high and a smile on our face, and by the end of the appointment, we crawled out of the room in tears. We could see that at every medical appointment, the doctors relentlessly discussed the diagnosis and prognosis until we started to cry, and it seemed like only our tears stopped them because then they could see the impact their words were having on us. When Tristan was just 2 years old, Fabian refused to attend medical appointments, and this caused a lot of friction in our relationship and put a big strain on our marriage. My suggestion for how the revealing of the diagnosis could have been managed differently would have been to plan for the conversation more and not be so rushed. Respond to the individual family's needs. Check what information the parents have. Some families may like to hear all of the information in one go, but offer family the choices of whether they want all of the information in one sitting or gradually so they can have an opportunity to process this at their own pace. Handing a family such devastating news at the end of the workday and then leaving is not great timing. We could have been given the information gradually. Maybe just the diagnosis, some information about what is the condition, and some reading material. Organize a follow-up appointment to discuss what the parents have understood and then build on that information. Rather than state that the child is most likely blind and deaf, it would have been better to state that a percentage, example, 50% of children are blind and 20% are deaf. Parents need to hold on to some hope. If parents choose to remain optimistic about their child's future, please let them. Eventually, they will have to face reality, and pressuring them to accept things immediately is not necessary. I could never understand why the consultant even said to us that Tristan's intellectual ability would be 0 when he was 12 days old. It's not possible to measure cognitive ability so early in a child's life. Telling parents that their child would have little to no intellect and they would not even be able to recognize them can devalue the individual with a disability. Every time a health professional said or did something that had a negative impact on us, I would spend a lot of time reflecting on why it happened. Was there someone who would gain from what had been said? And I could not find any winners in this situation. It made me wonder whether medical professionals said such things for the benefit of the parents. I wondered if they felt if it would be easier for the family to cut ties with the child if they felt they had no awareness. If that is the case, it is very unhelpful. The most important fact was that they are my children, and there is nothing that can be said to lessen my grief and sense of loss. If anything, such statements simply added to our pain. Let me share with you a poem by Emily Pearl Kingsley called Welcome to Holland, which uses the metaphor of a trip to Italy being a typical birth and child-raising experience, and a trip to Holland as the experience of raising a child with additional needs. It's like planning a fabulous holiday of a lifetime to Italy. You buy a bunch of guidebooks and make your wonderful plans. The canals of Venice, the Colosseum, Michelangelo's David. You may learn some handy phrases in Italian. It's all very exciting. After months of eager anticipation, the day finally arrives. You pack your bags and off you go. Several hours later, the plane lands. The stewardess comes in and says, "Welcome to Holland." Holland, you say? What do you mean Holland? I signed up for Italy. I'm supposed to be in Italy. All my life, I've dreamed of going to Italy. But there's been a change in the flight plan. They've landed in Holland, and there you must stay. The important thing is that they haven't taken you to a horrible, disgusting, filthy place full of pestilence, famine, and disease. It's just a different place. So you must go out and buy new guidebooks, and you must learn a whole new language, and you will meet a whole new group of people you would never have met. It's just a different place. It's slower paced than Italy, less flashy than Italy. But after you've been there for a while and you catch your breath, you look around and you begin to notice that Holland has windmills and Holland has tulips. Holland even has Rembrandts. But everyone you know is busy coming and going from Italy, and they're all bragging about what a wonderful time they are having there. And for the rest of your life, you will say, yes, that's where I was supposed to go. That's what I had planned. And the pain of that will never, ever, ever, ever go away, because the loss of that dream is a very significant loss. But if you spend your life mourning the fact that you didn't get to go to Italy, you may never be free to enjoy the very special, very lovely things about Holland. Research regarding barriers faced by people with disabilities recommended that health staff should work on an attitudinal change, and organizations should provide staff with relevant training. Reflecting on your own values, beliefs, and attitude towards a person with intellectual disability will help you in your practice. When you have to give the parent the diagnosis that their child could potentially be born with a cognitive impairment, it will help you share the information in a compassionate way without judgment or bias. Sometimes when I encountered health professionals who were difficult, I wanted to tell them that I too had not chosen this path and that I was thrust into it. I worked for about 12 years as a pediatric palliative care CNC and sat in on family meetings where parents were given a diagnosis. Sometimes the person leading the conversation would have a strong opinion and the conversation is held in a way to persuade the parents to choose one path over another. For example, parents are told that if they do not choose a one-way extubation, then it is possible that their child's life will be filled with suffering. I also feel that offering parents a smorgasbord of choices without any clear direction is unhelpful. As a health professional, parents will look to you for direction, and the best way to do it is to be clear about your recommendation and be even clearer about why you chose that recommendation over another. Since I was still in my 20s, it was recommended that we have genetic testing in case we wanted to expand our family. I was very reluctant and resistant to having another child after Tristan. But after 3 years of testing, we were contacted by the genetics team and informed that our tests had all been clear and that they could not find a genetic cause for Tristan's condition. Instead, they said that all men and women have faulty eggs and sperm. They explained that Tristan was an unfortunate accident where the faulty egg and sperm fertilized and carried to term. Fabian and I were told to disregard the genomes, exomes, and chromosomes, and that since we had a male with Leeson-Kefli, they would give us a 5% risk to have another male, but it would be 100% safe to have a female. Based on this conversation, Fabian and I decided to try for another child. We prayed for a girl who would be a companion for Danica, and again, I fell pregnant quickly. In order to be carefully monitored, I found an obstetrician who was an expert in high-risk pregnancies. My first meeting did not go well. He meant the conversation to be reassuring to me, but instead it was very distressing. We discussed my previous pregnancies, and I explained to him that it's only possible to diagnose Leeson-Kefli in the latter months of the pregnancy. I explained that I wanted to ensure that my pregnancy was progressing well and that regular monitoring would be reassuring for me because I was so anxious. He said that he had recently returned from overseas where he had conducted a late-term termination and proceeded to explain to me in great detail the procedure. I had only just found out I was pregnant, and I found this conversation too much. I chose to go down the public path and to use a midwife instead. I was scheduled to have 6 weekly ultrasounds to monitor the baby. My pregnancy progressed smoothly until at about 20 weeks, I felt fetal movements that was very rhythmic. Fabian and I were asleep at the time, and my tummy was against his back. The movements woke us both up, and we looked at each other in shock. It felt the same way as when holding Tristan while he had a seizure. I contacted the hospital, and they asked me to come in. They checked the baby's heart rate and told me that everything was okay, and that sometimes when a baby has hiccups, it can feel like a seizure. They reassured me and calmed me down, and I went home. I continued to feel these movements all through my pregnancy. At one of the ultrasounds at around 8 months into the pregnancy, I was told that they could see folds on Tiana's brain, which meant that Tiana did not have Leeson-Kefli. Fabian and I were overjoyed, and we started talking to Danica about her younger sister and all the things they could do together once she was born. On my due date, I went into labor, and Tiana was born on May 24th, 2000. When she was born, she had the same expiratory sounds like Tristan. Fabian and I felt again a strong sense of unease and asked for a neurology consult. Tristan's neurologist ordered a head ultrasound and told us that Tiana did not have Leeson-Kefli, but her head circumference was on the lower limit of normal. Fabian and I were still a bit uneasy, but only after this information we called our family and friends and informed them of Tiana's birth. We did this because we could not bear to endure what had occurred with Tristan. We had excitedly informed family and friends of Tristan's birth, and then shortly after had to tell them about his diagnosis and imminent death. When Tiana was 8 days old, she had a major cyanotic seizure. We rushed her to hospital, and since they had ruled out Leeson-Kefli, she too had a full workup, including a lumbar puncture. Finally, similar to Tristan, they organized a CT scan. Again, I thought it must be a bleed since they had ruled out an infection or electrolyte imbalance. The nurse who took us down for the scan told us that the consultants were in the room reading the scan, so we should get the results shortly. Again, after waiting for several hours, it was like deja vu. The neurologist, geneticist, radiologist, emergency doctor, and others took Fabian and me into a room and told us that Tiana also had Leeson-Kefli. I recall wailing until I became aware of my surroundings. I recalled seeing the head of the genetics department crying and realizing that this was as much a shock for her. This time around, no one made any dire predictions and instead once again asked Fabian to take care of me. I was overwhelmed with guilt for having another child who would live a life of pain and suffering. Going back to their diagnosis, lesioncephaly is an umbrella term for a neuronal migratory disorder. The surface of the brain is either smooth or has abnormal folds. There is a whole spectrum of this condition, and both my children had the severest form of this illness. I would like to briefly explain to you what having a diagnosis of lesioncephaly meant to Tiana and Tristan. Tiana only survived for 3 years and 3 months, but Tristan survived for 17 years and 10 months. Both Tristan and Tiana were nonverbal, but people who knew them well and understood their expressions could communicate with them. Owen learned to respond to yes and no questions by raising his hand or giving a thumbs up. They were unable to mobilize independently and they had to use wheelchairs. They had low muscle tone, which affected their head control, posture, breathing, their ability to swallow and clear their secretions. Therefore, they required frequent suctioning and were fed continuously via a gastrostomy tube. They had a whole spectrum of uncontrolled seizures. They required a lot of medication to manage their seizures, reflux, bowels, sleep, secretions, and breathing. They were incontinent. We massaged them daily, used equipment like standing frames, and gave them many passive stretches in order to keep their body in alignment. Even with all our care, with growth and the passage of time, as Tristan lived longer, he developed wrist and ankle deformities, dislocated hips, and scoliosis. They were predisposed to respiratory infections. They caught them easily and took longer to recover than the rest of the family. Tiana died due to a respiratory virus. Only after her death, a sleep specialist explained that it was obstructive sleep apnea. Tristan was diagnosed with obstructive sleep apnea and the treatment was CPAP. This machine helped Tristan breathe more comfortably and helped us to improve his quality of sleep. It made me so sad because if Tiana had accessed a CPAP machine, she may have survived longer. I believe that just having access to CPAP gave us longer and better quality time with Tristan. We wrapped Tristan in cotton wool and homeschooled him and did not use any out-of-home respite service because we were so afraid of him catching a respiratory illness and dying. Our lives were hectic, caring for our children, but we still managed to make many special memories and have fun along the way. Tristan and Tiana gave us so much happiness. I feel that Tiana's legacy was to start a new line of research with lesioncephaly. Until we had Tiana, researchers had not thought that lesioncephaly was linked to a recessive gene. Also, she helped us to feel like we could do anything. During her life, we had managed with 2 children with high needs, and it motivated us to do more for Tristan. Tristan achieved more only because he survived longer. The biggest lesson that Tristan taught us was patience. He never demanded anything. He always just waited for us to meet his needs. Sometimes I would be cross and say to Tristan, "Why did you not call me or make a sound so that we could assist you?" He would just give us a little smile that said, "I don't want to disturb you or be a bother." Our greatest sadness was not that we had children with disabilities, but that they had such a struggle. We would have given anything to lighten their suffering. Tristan taught us trust. Watching him travel through life, trusting that people around him would do the right thing by him. Even when we came across difficult people, he showed us that he could just let it pass and he focused on the kind, helpful people. Tristan taught us forgiveness. He shared his smile indiscriminately. Even when we came across an unkind, difficult person, he would smile at them, and it made us realize that if he could be forgiving, we could too. Tristan and Tiana taught us to love unconditionally. We have never loved anyone the way that we love our children. They gave us more happiness in their short lives than anyone could hope for in a lifetime. They made us kinder, more giving, and less selfish. The number of times that people have commented on our happy demeanors and the warmth and welcoming nature of our family made us so happy. They taught us resilience. The ability to smile through pain and suffering was incredible, and it made us learn to let the little things pass and to always step back and look at the big picture. Some people feel that people like Tristan and Tiana are inconsequential, but they made us feel so proud and so blessed every minute of every day. In conclusion, I would like to say that in general practice, you would often be seeing a family after the specialist has revealed a diagnosis. The GP is therefore in the best position to help the family process the information they have received, point them in the right direction, and offer them options for support. Within health, there is a hierarchy of health conditions, and the care that you receive varies dependent on the diagnosis. Having a heart attack or cancer generates much more compassion and support than genetic conditions. When a family has more than one child with a condition, health professionals' communication can come across as blaming you for being irresponsible. I hope that the next time you need to reveal a diagnosis or have a difficult conversation, you put yourself in your client's shoes and work to use language that is empathetic and kind. I promise you that with practice, it will become second nature. Do not be too hard on yourself when things do not go to plan, but use that experience to reflect and learn from so that the next time is better. Thank you.